morning everyone. At the outset I would like to thank our Anna, Dr. Gopal Pillai. So he has been actually last time in one of his this thing, I think it's a post banquet session, first session. So we are seeing, otherwise most of the times we see his hall so full that the speaker only doesn't get chance to sneak into and go if he comes late. So I once again thank you Dr. Gopal Pillai sir and esteemed co-instructors Dr. Natasha, Dr. Darai sir and our ever-loving Dr. DT sir. So I'll just to give a brief, we all know that it's a second most common cause, that's the after diabetic retinopathy. We have CRVO, BRVO, but recently TRVO, that is the tributary retinal vein occlusion, has been described. That is the involvement of the second or the smaller vessels as well. So with just tried for the sake of postgraduates sitting here, watching here, which includes hemodynamic changes, that is the venous stasis, degenerative changes of the vessel wall and the blood hypercoagulability. So these three play an important role in the pathogenesis of it. So RVO, all we know, it's about 5 in 1,000 cases, but what important here is the BRVO is 5 times more than CRVO, and the incidence is more if they are more than 80 years of age. So there are various causes for the loss of vision: macular edema, hemorrhage, neovascular, NVG, ERM, or the tractional retinal detachment involving the macula. So again, the ocular and the systemic workup is very, very important. Complete history, physical, fluorescein angiography and gonioscopy. We most oftenly try to miss it. The gonioscopy is very important to rule out any neovascularization at the angles, and of course a high magnification trying to look at the iris to rule out any NVI, but that is the signs to pick up so that we can stop them from going from non-ischemic to ischemic or various other complications. So again, complete blood workup, but I would like to suggest to make a tailor-made approach, not just to order all the investigations at once. So if the investigations initially are coming negative, then I suggest to go on more and more further. So the risk factor management, people have tried using anticoagulants, antiplatelets and fibrinolytics. Theoretically, yes, these drugs should help, but they have shown very little or no benefit from their use in most of the studies. So hemodilution is another way, that is decreasing the blood viscosity to enhance the blood circulation, and studies have shown slight improvement, but they are all monocentric. So there are a lot of treatment options available. Either we can do lasers, the intravitreal injections or the anti-VEGF injections. Surgical modality, I'll just come to it. But these are the common surgical modalities which we do in non-resolving vitreous hemorrhage, TRD, CRD or ARM. So these are the other surgical modalities which are worth to remember, but they are now almost become obsolete. Is the radial optic neurotomy, chorioretinal venous anastomosis, TPA injection through the retinal vein, the arterovenous sheathotomy as shown in this picture here, and SOAF, that is super selective ophthalmic artery fibrinolytic therapy. So what are the prognostic values of the retinal vein occlusions? The more the HRF, that is hyperreflective foci, as you see in this picture, poorer the prognosis. But there is interesting paper which says that the better prognosis when the HRF is present in the outer layers, not in the inner layers. So the HRF in the inner layers are more to find a poor prognostic factor. Again, more the drill at the baseline, again the worse is the prognosis. And here you can see that is the thickening of the middle limiting membrane, which says the signs of acute ischemia, ischemic damage, and these are the patients who usually have a slightly worse visual acuity. And PAM, if they are associated with paracentral acute middle maculopathy, now you can see even though there is no fluid here, even though there is no much of edema here, but these are the poor prognostic factors that's called as the OCT biomarkers in the case of the vein occlusions. Now coming to CRVO, there are various studies here. Apart from that, we have Horizon study, Retain, Shasta, Comrade, Crystal, Newton. So there are various studies which have been mentioned here. In non-ischemic CRVO with no macular edema, we usually observe monthly for first 3 months and then later 3 monthly. And of course, we have to look in for signs of conversion to ischemic CRVO. So if the visual acuity is less than is around 6/90 or more than that, then anti-VEGF or the Ozurdex. Less than that, I would rather prefer Ozurdex, but many people prefer anti-VEGF also. But if the visual acuity is better than 6/12, then they can usually be observed, provided they are non-foveal involving edemas. So the choice of injection, again, there is plethora of injections available now in the market. You have DEX implants also, usually better choice in patients with recent cardiovascular events and those who do not favor monthly injections. So switching to other anti-VEGFs, this is another study which switched ranibizumab in eyes, no responding to bevacizumab. So they found the significant improvements. Again, switching to aflibercept in eyes, not responding either to bevacizumab or ranibizumab, showed significant improvement anatomically compared to BCVA. So in non-responsive cases, the only methodology left with us is to switch these anti-VEGFs or switch from anti-VEGFs to steroids. In ischemic CRVO, and definitely anti-VEGF with early PRP, but if there is NVI or NVA with closed angle and normal IOP, then it's always better to add AGV along with anti-VEGF and later on PRP. But definitely if the pressure is very high, then we have to inject anti-VEGF, regress the vessels at the angle so that the IOP normalizes, and then plan for AGV followed by PRP. So in case of BRVO, again you can see lot of trials are available, BVOS, Bravo, Horizon, Retain, Comrade, Brighter, Vibrant, Marvel, Omar. So just to give a brief of that, if the visual acuity more than 612, then many of the studies or many authors would love to observe them monthly initially. But if it is worse, then anti-VEGF or steroid as and when required, and still no improvement, then we need to assess for the macular ischemia. And of course now OCTA is now the handy machine. If you don't have, then even fluorescein angiography we can try to recognize, looking for macular ischemia. But if the visual acuity is 6/12 or worse with macular edema, again the first choice is anti-VEGF, and if it is recurrent, then the choice goes shift towards the steroid implants. In ischemic, no macular edema, no neovascularization, FFA more than 5 disc diameters of CNP to observe. If there are macular edema, then go ahead with anti-VEGF. No macular edema, but however we find the neovascularization with or without associated vitreous hemorrhage, then these are the cases for sectoral PRP. So management of hemiretinal vein occlusion is almost as similar on signs of BRVO. These are last 3 cases. I would like to end my talk. In this case, you can see here, this is the sclerosed vessel with the vitreous hemorrhage. So the most important I would like to do is just to do a sectoral PRP and wait for the vitreous hemorrhage to resolve. If it's not, if it's complicating or if it's not going, or the patient complains of floaters, then only I would like to go in for PP, pars plana vitrectomy with endo laser in this patient. So this is another case of right eye ST BRVO with recurrent macular edema. So in these cases, I would rather prefer to use DEX implant because the monthly injections might be difficult. But however, the long-term injections, long-lasting injections like brolizumab hasn't got still approval for the use of retinal vein occlusion. But aflibercept is again a good alternative. But again, the economics also of the patients also have to be considered, especially for people like me who are practicing in tier 2 cities. So this is the another case. You can see here the pre-op, there is a vitreous hemorrhage. There is quite a lot of membranes here which is causing traction in the macula, and also there is vitreous hemorrhage. So I think these are the definite cases where just lasering will not help. In fact, lasering might cause more contraction, and even just doing the laser also might cause contraction. If we do the laser and leave it, it might cause contraction and worsen the traction over the macula. So this is the best way to go ahead is just do a pars plana vitrectomy, remove this fibrotic membranes, laser those areas wherever we find the ischemic or the sclerosed areas, vessels are seen under the under guarded visual prognosis. So in last case, so this is the BRVO with FEP extending towards the macula. I think these are the cases, if they have good vision, they can be observed. But if the vision is dropping, I think these are the cases where you can see that the traction is already threatening the fovea or involving the fovea, and doing a vitrectomy and saving the further loss of this vision. That's how I explain to my patients that you might not benefit much from these. You might not get a good visual acuity, but definitely we try to save the existing vision. That is what is more important in this case. So this is the whole chart, what I was talking about. It contains most of these in the different arrows of the flow chart. And I would like to acknowledge our fellow Dr. Rajeshri Salvi and the Department of Vitreoretina at JOSHI Institute. Thank you very much once again.
Thank you, Srinivas, for that very enlightening talk. So the basic difference between the AMD, as Dr. Dinesh Talwar is setting up his presentation, the basic difference is here, if your duration of quiescence, if it is less, then you will immediately move to Ozurdex than from one anti-VEGF to the other, right?
Yeah. Sir?
So how many months of inactivity do you want post anti-VEGF injection for shifting towards Ozurdex?
Yeah, course, many of them try for 3 monthly injections, but I shift after second, or sometimes even after the first injection. If I don't see any response at all,
Then why
or
do you
there
want
is
to
a
give?
worsening, there is
Okay.
a worsening. I have seen that in many of the cases where the cystoid spaces become tall, the SRF has increased, and I usually don't jump in for the second injection in those patients. But if subminimal response is there, I usually go in for the second dose. If no response even after the second dose, then I switch them to the DEX implant.
Thank you very much.